Good morning, doctors. The topic of the lecture is pathology of endocrine system in children. The endocrine system performs extremely important functions in the human body. It is involved in all of the integrative aspects of life, including growth, sex, differentiation, metabolism, and adaptation to an ever-changing environment. The endocrine system participates in the regulation of digestion, use and storage of nutrients. The endocrine system once was thought to consist of discrete endocrine glands, hypothalamus, hypophysis, thyroid and parathyroid glands, adrenal glands, pancreatic islets, gonads. It is known now that the number of other tissues release hormones. For example, kidney produces erythropoietin, which participate in the red blood cells production. Digestive tract produce motilin, serotonin. Adipose tissue produce leptin. The function of endocrine system are closely linked with those of the nervous and immune system. Let's start from one of the most common endocrine disorder, diabetes mellitus. Diabetes mellitus is a chronic metabolic disorder caused by an absolute or relative deficiency of insulin, an anabolic hormone. The incidence of diabetes is increasingly rapidly worldwide of a known reason, and it is most common in people of European descent. In Western population, the classic childhood form of type 1 diabetes affects 1 in 250-350 people. Each child has a 0.3 to 0.4% risk of developing diabetes by the age of 20 years. Classification of diabetes mellitus includes, first of all, type 1 insulin-dependent diabetes and type 2 non-insulin-dependent diabetes. But there are also other types. Appearance of diabetes symptoms after drug treatment, for instance, glucocorticoids can cause steroid diabetes. Treatment with L-asparaginase can cause signs of diabetes. Gestational diabetes, diabetes as a complication of pancreatic diseases, mainly cystic fibrosis, hemochromatosis. Diabetes in the cases of genetic syndrome, Turner syndrome, Down syndrome. The predominant form affecting children is type 1 diabetes mellitus. Other forms are uncommon in childhood and are usually accompanied by obesity, pancreatic disease, and rare syndromes. Pathogenesis of diabetes mellitus can be characterized as autoimmune disorder with genetic predisposition. Over 90% of patients with type 1 diabetes possess either HLA-DR3 or HLA-DR4 antigens. The genetic factors alone are not responsible for the disease. The genetic factors appear to predispose the patient to an autoimmune process. At some unknown point in time, a trigger, possibly a viral illness or other environmental factor, initiates an autoimmune response. cell antibodies are present at clinical onset in 90% of patients. Patients also may have spontaneous anti-insulin autoantibodies at diagnosis. Abnormalities in cellular immunity exhibited by the ratio of T helper to T suppressor cells have been shown. Type 1 diabetes has long been known to be associated with other autoimmune diseases such as Hashimoto thyroiditis, Graves' disease, Addison disease, celiac disease, and juvenile rheumatoid arthritis. Evidence of autoimmunity in the form of islet cell autoantibodies and anti-insulin autoantibodies may be present for months to years before the clinical appearance of disease. During this time, there is progressive destruction of insulin-secreting tissue. The clinical manifestations of overt diabetes, such as polyuria, polydipsia, polyphagia, and weight loss, become manifest only when insulin secretory reserve is reduced to 10 to 20% of normal. Insulin is essential to process carbohydrate, fat, and protein. Insulin reduces blood glucose level by allowing glucose to enter muscle cells and fat cells and by stimulating the conversion of glucose to glycogenesis as a carbohydrate storm. Insulin also inhibits the release of stored glucose from liver glycogenolysis and slows the breakdown of fat to triglycerides, free fatty acids, and ketones. Additionally, insulin slows the breakdown of protein for glucose production, gluconeogenesis. Clinical manifestations of diabetes mellitus include such typical symptoms as polyuria, polydipsia, polyphagia, weight loss. Some children complain of general malaise, headache and weakness, skin dryness and itching. With progressive insulin deficiency, excessive glucose production and limited utilization result in hyperglycemia with glucoseuria when the renal threshold of 180 mg per deciliter is exceeded. The resultant osmotic diuresis produces polyuria, dehydration, and compensatory polydipsia. Insulin deficiency leads to uninhibited gluconeogenesis, causing breakdown of protein and fat. Babies' appetite usually remains good. Failure to thrive and wasting may be the first symptoms preceded frank hyperglycemia. About 10% of patients present with diabetic ketoacidosis with dehydration, Kussmaul respiration, the fruity odor of acetone, cerebral obtundation. Ketoacidosis is more commonly the presenting feature in children less than 2-3 years old. The evolution of diabetic ketoacidosis may take hours to days. Polyuria, polydipsia, nausea, vomiting, and anorexia are usually the major presenting manifestations. Abdominal pain due to paralytic ileus or gastric distension may mimic an acute abdominal condition, is common in children but often resolves with intravenous fluid therapy. Dehydration, Kussmaul respiration, the fruity odor or acetone on the breath, and altered mental status ranging from disorientation to coma are the major signs. The main laboratory findings are hyperglycemia, glucosuria and ketosis, ketonemia and ketonuria, random plasma glucose measurement that reveals levels greater than 200 mg per deciliter, and urine analysis usually suffice diagnostic tests in the symptomatic patient. The oral glucose tolerance test should be reserved for doubtful cases or patients with asymptomatic hyperglycemia. A glycosylated hemoglobin measurement reflects the time average integral of the prevailing blood glucose concentration over the preceding 6-8 weeks. Uncompensated metabolic acidosis occurs plasma-based bicarbonate level less than 15 milliequivalent per liter and pH less than 7.3. Plasma sodium level is variable with total body deficit. Plasma potassium level is variable with a significant body deficit caused by transfer of potassium out of cells associated with the acidosis and dehydration. Urine analysis shows acid reaction, high specific gravity, glucosuria and ketonuria. When dehydration is present, the hemogram reveals an elevation of hemoglobin and hematocrit level. The principles of diabetes management involve appropriate using of insulin, providing nutrition consistent with the requirement of a growing child, and regular physical activity. The nutritional requirements of diabetic children are similar to those of healthy children of similar age, sex, weight, and activity. The total caloric intake is 1,500 kilocalorie per meter square. The calories should consist of approximately 55% of carbohydrate, 30% of fat, and 15% of protein. It is recommended that approximately 70% of the carbohydrate content be derived from complex carbohydrates such as starch, whereas highly refined sugars be avoided. Diets with high fiber content are useful in improving control of blood glucose by delaying the absorption of food. The cholesterol intake should be reduced. Patients with diabetes mellitus are encouraged to physical activity. A regular exercise program is highly beneficial. Special adjustment in meal planning and insulin dose must be made during anticipated vigorous exercise to avoid hypoglycemia. Insulin therapy is the main treatment approach. Commonly available insulins are rapid-acting insulin, for example, Humalog, short-acting insulin, for example, regular insulin, intermediate-acting insulin, for example, Lanta, long-acting insulin, for example, Protamine, Zinc, Ultralanta. Some authorities are concerned about the use of long-acting insulin in children because they fear the development of hypoglycemia. And pre-mixed insulin available as a combination of several types of insulin. Rapid-acting insulin is taken just before or after meals to control spikes of blood sugar. It often works in 15 minutes, peaks between 30 and 90 minutes and last 3 to 5 hours. Short-acting insulin, regular insulin, takes effect in about 30 minutes to 1 hour and peaks after 2 to 4 hours. Its effects tend to last about 5 to 8 hours. The biggest advantage of short-acting insulin is that a patient doesn't have to take it at each meal. We can take it at breakfast and supper and still have good control. Intermediate-acting insulin can control blood sugar levels for about 12 hours or longer, so it can be used overnight. Intermediate-acting insulin offer baseline insulin coverage and can be used with short-acting insulin or rapid-acting insulin. Pre-mixed insulin, Humulin or Novolin 70/30. This type of insulin combines intermediate and short-acting insulin. It is often taken twice a day before meals. It should be taken 10 minutes to 30 minutes before eating. Pre-mixed insulin takes effect in 5 to 60 minutes and its peak times vary. Its effect lasts from 10 to 16 hours. The most common is to give 2 daily injections, combining intermediate-acting and short-acting insulins. The ratio should be approximately 2 to 1 or 3 to 1 of intermediate-acting insulin to the short-acting insulin, with about 2/3 of the total daily dose given in the morning before breakfast and about 1/3 of the total dose given in the evening before supper. On the picture you can see the most often used places for insulin injection. Of course, individual adjustments are made according to individual response to the treatment. At the onset of the disease, when endogenous insulin secretion is still present, the total daily dose may vary between 0.2 to 0.7 unit per kilogram per day. After about 1 year of established disease, the dose of insulin tends to be about 1 unit per kilogram per day. Special attention should be given to the management of such critical condition as diabetic ketoacidosis. The major life-threatening complication in children treated for diabetic ketoacidosis is cerebral edema. Children with diabetic ketoacidosis are hyperosmolar due to hyperglycemia. Too rapid correction of hyperglycemia and osmolality may result in rapid shifts of water from the extracellular to the intracellular compartment, predisposing the patient to cerebral edema. The guidelines for diabetic ketoacidosis management includes, first of all, fluid replacement, then insulin replacement and carbonate therapy. Fluid replacement means slowly correcting the fluid deficit over 24-48 hours. In a child with severe acidosis or compromised circulation, an initial resuscitation of 10 to 20 milliliters per kilogram of isotonic 0.9 sodium chloride solution can be administered over 30 minutes. When glucose levels have fallen to 12-15 millimole per liter, 5% glucose solution should be introduced. Insulin replacement therapy means injection of priming dose 0.1 unit per kilogram regular insulin intravenously with continuous intravenous infusion 0.1 unit per kilogram per hour regular insulin. When the blood glucose concentration approaches 16 millimole per liter, discontinue the insulin infusion and start insulin therapy by subcutaneous injections of 0.2 to 0.4 units per kilogram at 6-hour intervals. Bicarbonate therapy means infusion of 40 milliequivalent per meter square of bicarbonate over 2 hours if pH drops to the level of 7.0 7.1. Another critical condition in patients with diabetes mellitus can be caused by wrong dose of insulin. It's insulin-induced hypoglycemia. Hypoglycemia, characterized by weakness, headache, pallor, diplopia, sweating, and twitching. Blood sugar level is less than 3.3 millimole per liter. Hypoglycemia is managed by giving sugar, orange juice, or milk. If the reaction is severe with loss of consciousness or inability to swallow, glucagon in dose of 0.5 to 1 milligram is given subcutaneously, intramuscularly, or intravenously. Intravenous bolus injection of hypertonic 10 to 20% of glucose solution 1 milliliter per kilogram. Then intravenous continued infusion of hypertonic glucose solution up to the blood glucose level 7 to 11 millimole per liter. Now let's talk about disorder of the thyroid gland. The thyroid gland is a vital endocrine gland. It plays a major role in the metabolism, growth, and development of the human body. Tyrotropin-releasing hormone synthesized in the hypothalamus governs the pituitary gland's release of thyroid-stimulating hormone that stimulates the synthesis and release of thyroid hormones. The thyroid gland secretes thyroxine or tetraiodothyronine, triiodothyronine, and calcitonin. Hyperthyroidism results from excessive secretion of thyroid hormone and, with few exceptions, is due to Graves' disease, diffuse toxic goiter. Graves' disease is an autoimmune disease characterized by production of autoantibodies to the thyroid-stimulating hormone receptors. The thyroid is enlarged because of constant thyroid-stimulating hormone receptor stimulation. Onset of Graves' disease has been attributed to acute infections and to both physical and emotional stress. Clinical manifestations of Graves' disease includes emotional disturbances. The children become irritable, excitable, cry easily, motor hyperactivity, tremor of the fingers, voracious appetite combined with loss of weight, exophthalmos, infrequent blinking, the skin is smooth with excessive sweating, tachycardia, systolic blood pressure increased, heat intolerance, weakness. Thyroid crisis or thyroid storm is a form of hyperthyroidism manifested by acute onset, severe hyperthermia, severe tachycardia, restlessness, rapid progression to delirium, coma, and sometimes death. Laboratory data typical for Graves' disease are serum levels of T4, T3, free T4 and T3 are elevated. Level of thyroid-stimulating hormone is suppressed. Elevated level of antibodies to thyroid-stimulating hormone receptors. Ultrasonography shows thyroid gland enlarged and homogeneous. For the treatment of Graves' disease, thermostatic drugs are recommended. Propylthiouracil 100 to 150 mg 3 times daily, or metimazole 0.5-0.7 mg per kilogram once daily. Adequate control is evident in 1 to 3 months. The dose is decreased to the minimal level required to maintain euthyroid state. Subtotal thyroidectomy is indicated if medical management has failed. A beta-adrenergic blocking agent such as propranolol is useful in management of severe toxic patients. In the pediatric practice, special attention should be given to congenital hypothyroidism. Developmental defects, thyroid dysgenesis, account for 90% of infants in whom hypothyroidism is detected. Clinical manifestations in newborn infants includes gestations more than 42 weeks, birth weight more than 4 kg, hypothermia, lethargy, large tongue, poor feeding, edema, dry skin, hoarse cry, abdominal distension, constipation, umbilical hernia, large posterior fontanelle. Congenital hypothyroidism needs early diagnosis and treatment from the first weeks of life. Thyroid hormones are crucially important for maturation of such tissues as brain and bone. If the diagnosis is missed and therapy instituted after 6 months, when clinical features of hypothyroidism cretinism are apparent, the likelihood for normal intellectual development is markedly decreased. Also, growths are returned to normal. European screening programs for congenital hypothyroidism are based on primary measurement of thyroid-stimulating hormone in the first days of life. Level of TSH is elevated. Serum level of T4 and T3 are low. For treatment, replacement therapy with L-thyroxine at a dose of 100 microgram per kilogram, per meter square per 24 hours is recommended. Another important endocrine glands are adrenal glands. The adrenal gland consists from the outer layer cortex, which synthesize steroid, and inner layer medulla synthesize catecholamines. Adrenal cortex consists from zona glomerulosa, which produces mineralocorticoids, aldosterone, with main function of retention of sodium and water by kidney. Zona fasciculata produces glucocorticoid cortisol, with main function to keep blood glucose level, and zona reticularis, which produces sex hormone. The hypothalamic pituitary adrenal axis comprises a classic negative feedback system. A hypothalamic corticotropin releasing hormone stimulates the pituitary gland to release adrenocorticotropic hormone. Adrenocorticotropic hormone governs the synthesis and release of cortisol. Exogenous cortisol suppresses adrenocorticotropic hormone. Hypofunction of adrenal gland or adrenocortical insufficiency can be classified into primary as a result of adrenal injury or secondary as a result of hypothalamus or hypophysis injury, and acute or chronic. Etiology of adrenocortical insufficiency includes pituitary hypoplasia or destructive lesions, craniopharyngioma, primary adrenal hypoplasia, defects of steroid biosynthesis, adrenal hyperplasia, destructive lesions of adrenal cortex, for example tuberculosis, autoimmune adrenalitis, Addison disease, acute meningococcal infection, Waterhouse-Friderichsen syndrome with bleeding into adrenal glands, abrupt cessation of exogenous corticosteroids, and drugs toxic to adrenal glands, ketoconazole, rifampicin, phenobarbital. Disorder with acquired adrenocortical insufficiency is Addison disease. The most common cause is autoimmune destruction of adrenal cortex. The disease manifests with muscular weakness, anorexia, loss of weight, general wasting, low blood pressure, increased pigmentation of the skin on the face, hands, axilla, joints. Adrenal crisis manifest with suddenly cyanosis, cold skin, weak pulse, tachypnea, low blood pressure. The cause may be rapidly fatal without intensive therapy. Typical laboratory changes for Addison disease are low level of serum sodium and chloride and elevated potassium, hypoglycemia, increased number of blood eosinophils, low plasma level of cortisone and aldosterone. For the confirmation of the diagnosis, ultrasound and CT of the adrenal glands should be done. Patients with acute Addison disease should be treated with intravenous 5% glucose and 0.9% saline solutions to correct the hypoglycemia and sodium loss. With intravenous hydrocortisone 25 mg for infants and 75 mg for older children at 6-hour intervals for 24 hours. Desoxycorticosterone acetate 1 to 5 mg per 24 hour intramuscular. For chronic replacement therapy, patients achieves orally cortisol 15 mg twice daily and fluorohydrocortisone 0.1 mg per 24 hours. The most common form of congenital adrenocortical disorder is congenital adrenal hyperplasia, adrenogenital syndrome. It is autosomal recessive disorder of adrenal steroidogenesis due to enzyme deficiency 21 hydroxylase, 11 hydroxylase, 17 hydroxylase, leading to a deficiency of cortisol and overproductions of androgens. The deficiency of cortisol results in increased secretion of adrenocorticotropic hormone, which leads to adrenocortical hyperplasia. Adrenogenital syndrome has several clinical forms. One of these forms is virilizing form. Males normal at birth and signs of sexual and somatic precocity may appear within 6 months of life or develop at 4 to 5 years of age or later. Enlargement of the penis, scrotum, appearance of pubic hair, deep voice, muscle well developed, bone age is advanced. In females, evidence of masculinization at birth, enlargement of clitoris. 2% of females have a male phenotype. Second form is salt-losing form of adrenogenital syndrome. Symptoms begin shortly after birth with progressive weight loss, dehydration, vomiting, anorexia, disturbances in cardiac rate and rhythm, cyanosis, dyspnea. Without treatment, collapse and death may occur. Typical laboratory changes are low serum concentration of sodium and chloride, elevated levels of potassium and 17-hydroxyprogesterone, blood levels of cortisol are low, increased levels of testosterone and urinary 17-ketosteroids. Karyotype and ultrasonography are also helpful for the diagnosis. Patients with adrenogenital syndrome needs substitutional treatment with glucocorticoids. Administrations of glucocorticoids inhibits excessive production of androgens and stamps virilization. Hydrocortisone 20 to 25 mg per meter square per 24 hour orally in two divided doses should be given. Patients with disturbances of electrolyte regulation, salt losers, require mineralocorticoids in addition to the glucocorticoid. Fluorocortisol 0.05 to 0.1 mg once daily. Plasma level of 17-hydroxyprogesterone, testosterone is adequate indices of control. There are two clinical forms of hypercorticism with hyperproduction of glucocorticoids. First of all, Cushing syndrome and then Cushing disease. Cushing syndrome caused by adenoma of zona fasciculata of adrenal cortex can be iatrogenic in the course of treatment with glucocorticoids or caused by ectopic productions of adrenocorticotropic hormone by some tumors, for example lung cancer. Cushing disease, it is basophilic adenoma of adenohypophysis. Typical clinical symptoms of Cushing syndrome or disease are obesity, moon face, purplish stria on the hips and abdomen, muscle weakness, osteoporosis, arterial hypertension, hyperglycemia, steroid diabetes, pubertal development delayed. For the diagnosis confirmation, the next investigation are necessary. CBC shows polycythemia, lymphopenia, glucose level is increased, potassium level is decreased, increased serum cortisol level and urinary excretion, CT scan to detect adrenal tumors, MRI to detect pituitary adenoma. Treatment approaches are unilateral adrenalectomy in the case of benign cortical adenoma and pituitary adenoma resection or radiotherapy. Thank you for your attention.